Okay, so we've looked at bag valve mask ventilation of a patient in a non-emergent situation. We've demonstrated a very basic intubation at the bedside. So what can happen, and we're going to talk more about it in a pre-hospital setting, we have two options that could happen if we can't get the patient intubated. We can either do an emergency cric or a tracheostomy. Doctors typically do that percutaneously at the bedside. It's a much more controlled environment, many more hands on deck to assist in that surgical procedure. I'm going to demonstrate a surgical cric, which are done often in the ERs and often in the streets in trauma situations. So let's go back and pretend I was bag valve masking this patient, and we're having a lot of difficulty bagging the patient due to severe facial trauma, we'll say. I can't get a good seal with my mask on the patient's face. I'm unable to bag them. So I rapidly grab my laryngoscope and my endotracheal tube, and I go in to try to get this patient intubated rapidly because they're typically not breathing or they're not oxygenating well. And we realize real fast that your landmarks that we look for when intubating a patient and where to place the tube are unrecognizable. There's so much trauma to the neck and the mouth. So at this point, we fall back to something we call a rescue airway. And we call it a rescue airway because it rescues the patient, but it also helps us in these stressful moments. So we've got a situation where I'm going to have to place a subglottic airway. This is a blind intubation where I just place this into the patient's mouth, and I have one cuff to inflate. And this is what it looks like in the patient's mouth. You will see patients with these in their, or have had these in the ICUs that have experienced trauma. So this is basically placed inside the patient's esophagus. This is placed inside the patient's mouth. You can see that's quite damaging to the mucosal membranes and can be quite uncomfortable. These are not kept in the patient for long. This is basically placed inside the street or on a rapid response call where a doctor can't get somebody intubated due to the patient's morphology or pathophysiology. Big tumor in the neck, and you just can't see those vocal cords to get the tube through. So let's just pretend at this point the doctor or the flight team or the paramedics decide to do an emergency cric. And what a cric is it goes through the cricothyroid membrane right above the hyoid bone. So the trick to this technique is finding your landmarks. It's very easy on a guy my size who's quite skinny with an Adam's apple. It's typically you find the Adam's apple on a man, you go down until there's a notch. You know your hyoid bone is right below it, and there's a huge gap that you can feel quite easily on somebody who's skinny. And that's where you want to make the incision. There's other techniques, if the person's quite obese, you could pull the skin folds back to try to expose the larynx and see where that membrane is that we need to penetrate to put an airway in. Typically when this is occurring, it's a very stressful situation because this is the patient's last resort to get oxygen, and it's very stressful on the clinician performing this procedure. But typically it's a pretty easy procedure. You want to be very careful not to penetrate any arteries, especially along the thyroid glands. So it's something that you need to take time with, and you need to keep a steady hand that you're not going to cut any vessels. That's going to also impede your view of placing the tube and cause harm to the patient. So let me demonstrate on the mannequin here. Let's just say I found my landmark. Once the landmark is found with my finger, I'm going to keep my finger on it once I have identified that landmark. So I've found the landmark. This is a mannequin that we practice crics on, and I put a piece of tape over to make it feel like skin. I'm going to take a scalpel. You get into the position of comfort. I typically like to be at the patient's head when I'm managing it. I would have suction on hand. I would have my partner with me, and this is an emergency situation. If I could provide the patient with the analgesic therapy, I would. Often in these situations, there's no time. So we're going to take the scalpel. You're going to make a vertical incision along the cricoid membrane, and you make a vertical incision, I would say about ½ an inch long. We are going to be placing a 4 or 5 endotracheal tube. Once you have penetrated, cut through the skin, you're going to turn your scalpel to the up and down position, and then you're going to puncture the membrane. You're just going to stick this into the membrane like that. I recommend never removing the scalpel until you've got either a bougie, which is a plastic introducer, or some type of a hemostat to keep your landmark. Because once you pull this out, you've got a very sharp object floating around the back of an ambulance or in an ER, which can be dangerous, and you've lost your landmark. These tend to close up, there's a lot of fluid, and you'll lose your landmark. So I always recommend leaving the scalpel in place until I have something, either hemostats, sterile hemostats, into the position. So let's just say I have a set of hemostats in position. I'll get a pair and show you after. I could remove the scalpel, making sure that it's kept away from the team. I would open my hemostats to expose the opening, and I would take my endotracheal tube. You can do a cuff tube or a non-cuff tube, and you'd place this into the patient's airway. You would go down just like you would when you're intubating a patient, get that black line on all tubes past the vocal cords. This would be inserted. Once that's in place, you remove your stylet, and you would bag the patient like you would on any other any other bag valve mask situation. And you can see here, I'm actually right mained on this, so I would pull the tube back a little bit so I can get both lungs. And there you go, it's opening up there. So if you right main, if you push the tube in too far, whether you're endotracheal tube intubating somebody or doing a cric, the way that the morphology is on a patient's bronchus and bronchioles is the right main is up higher and more easily tubed. So if we place a tube and I only have breath sounds on the right side, I typically pull the tube back a centimeter at a time until I have left side lung expansion. One thing we look for in the field is that we keep pulling the tube back and we still don't have lung sounds. Hopefully you caught that before you were intubating, that they could have a pneumothorax, but we've assessed that prior. So we went through the evolution. We saw how to bag valve mask a patient, and it's not really invasive. It's not considered to be invasive. We progressed on to a endotracheal tube intubation, and you can see whenever we put metal in people's mouths, it's just very traumatic. And we as practitioners in the field try not to intubate people if we don't have to. We can use other non-invasive measures, but at times when the patient can't protect their own airway, when there's lots of secretions involved, or the patient's not oxygenating or ventilating well with a very low mentation, we will intubate them. And it's traumatic. Depending on the patient or the provider's experience level, if they're a new paramedic or a flight nurse or to somebody with lots of experience, I think really gauges the type of trauma that could be given to the patient. We demonstrated a failed airway where we had to use a subglottic airway because of the difficult intubation, and then we progressed on to our last resort, which is a emergency cric. So I think the takeaway point here is to realize that it's very traumatic. It's a life or death situation on many occurrences, and that these patients are going to experience pain and have all types of oral and throat ENT situations post this type of event. So I hope that helps.